What's up, Ninja Nerds? In this video today, we're going to be talking about pulmonary sleep disorders. This is a part of our clinical medicine section. And if it helps you, it really does make sense, please support us. You can do that by hitting the like button, commenting down in the comment section, and also subscribe. I also really suggest go down in the description box below. There's a link to our website. There we have a lot of cool stuff that I really suggest that you guys become a member because you guys can access really great notes, illustrations, questions. On top of that, we're even developing exam prep courses for those of you who are taking your boards exams. So go check that out. We even got some cool merchandise as well. So let's start talking a little bit about these disorders. So there's really two types that I want to discuss, but there's this little other extra one that we're going to kind of toss in there a little bit. But the two primary ones are going to be obstructive sleep apnea and obesity hypoventilation syndrome. Now, in obstructive sleep apnea, these patients, it's within the word, while they're sleeping, they develop apneic events. They stop breathing, and it's because of an obstruction in their airway. There is this other entity which we call central sleep apnea, a little bit less common, but they go apneic, they stop breathing while they sleep due to a central drive suppression. And we'll talk about what that looks like as well. But let's first focus on obstructive sleep apnea. What are the reasons why they're obstructing their airway? There's a couple. One is there's some type of nasal airway obstruction. So something is obstructing the airflow. Maybe if you take a breath in through your nose, it's supposed to run through these turbinates and then down here and into the airway, correct? What if there's an obstruction somewhere in this pathway? That could definitely cause this, right? So this could be things like you have a deviated septum. So this could be a deviated septum that could narrow one of the actual sides of the nasal cavity. Another one is that you could have potentially really enlarged tonsils or a uvula or a soft palate. All of that would obstruct right here in that nasopharynx. So if you have enlarged structures, and what would that be? Again, just to remind you, a couple of them. I would say uvula would be a big one. Soft palate would be a big one. And then lastly could be those tonsils if you have really, really enlarged adenoid tonsils. So those would be a couple different things that I think would be really, really important. So enlarged structures and a deviated septum. These things can most certainly obstruct the nasal passages and the nasopharynx. What about somewhere particularly in here, like at the tongue, the oropharynx area? This one is actually usually due to medications. So for example, if someone decides to take some medications that leads to the relaxation of these muscles. And what I mean by is I cause the tongue to relax, I cause some of the pharyngeal muscles to relax, and what they do is they start sagging backwards. So imagine this tunnel right here is going to be narrow because the tongue starts sagging backwards and the muscles that are on this side start sagging inwards, and then you obstruct that airway. What will be some things that would relax those pharyngeal muscles? Usually, sometimes people take it for this reason, but alcohol, to go to sleep. Unfortunately, that can't obstruct the airway. And another one is benzos. So benzodiazepines. So in this particular scenario here, these are the things I want you to think about because what do? They definitely obstruct the airway, but they do it via different mechanisms. It's not an obstruction directly. It's these things cause relaxation of the pharyngeal muscles, which then provoke obstruction. All right? Last one, I'd say by far the most common one, is going to be a patient who has a really, really large neck. So if they have a really, really large neck in this particular scenario here, and it starts sagging back and compressing on this airway, that would definitely be a trigger. This is usually obesity. Sometimes we say these patients have what's called bull necks. And this can definitely be a big, big factor here. I'd say probably one of the most common causes. So whenever you have these particular scenarios here, this all increases the risk of airway obstruction, and this impedes airflow through the actual trachea, lungs, all of those effects. So if I'm not getting as much airflow coming down here, then what happens is I don't aerate my lungs, and I don't ventilate them is another better way of saying this. But the big thing to remember is that this is more particularly common when they're sleeping. So when these patients are sleeping, all of these problems come into play. They obstruct the airway. They don't get airflow while they're sleeping. What happens? Let's come down. The effect here is that you don't ventilate the alveoli. So these patients experience what we call obstruction of the airway, which leads to what we refer to as alveolar hypoventilation. In other words, you don't generate enough movement of gases that'll flow into the lungs and out of the lungs, okay? So this is going to be impaired. If this is impaired, this impairs the amount of oxygenation of the blood and clearance of CO2 from the blood. So now this is impaired. And if I can't clear these molecules, as the blood runs through these pulmonary capillaries to undergo gas exchange, it's going to leave with what? Two effects here. One is the patient will experience a drop in their oxygen within the blood, right? So we call this hypoxemia. But they'll also experience an increase in their CO2, which we call hypercapnia. So they can have a low O2 and a high CO2. But the big thing to remember is that this is nocturnal. This is only nocturnal. And that's the big difference here. So this alveolar hypoventilation that you're seeing here will then lead to these effects here, which is going to be hypoxemia and hypercapnia while they're sleeping. Now, the problem with this is that these patients don't oxygenate multiple different tissues while they're sleeping. And you know what the problem with that is that they don't get very good quality sleep. And so when they wake up, they're so exhausted throughout the day. And the classic finding in these patients is going to be they experience some type of like daytime somnolence. Sometimes this can even increase the risk of these patients having like motor vehicle accidents or being less productive during the day. So this is one of the most classic findings. Sometimes you may experience headaches, but I think when a patient has obstructive sleep apnea, really what you want to look for is, are they having a couple things? Daytime somnolence, all of these features with the most important one being obesity, and then the other concept is there any witnessed events by the partner who's sleeping next to the patient of where they're snoring because of the obstructed airway, or they're having periods of where they stop breathing during the night. That's classic. With that being said, this is more suggestive of obstructive sleep apnea. There is this entity where you have a respiratory drive center, and it's supposed to send signals down to the nerves that go to the muscles and all of these things that are supposed to help your muscles to contract and breathe properly. But what if for some reason this respiratory drive center is suppressed? There could be a plethora of reasons, but the most common reasons is these patients usually have something called CHF. And during CHF, what they do is they're tachypnic and they breathe down their CO2, which suppresses the respiratory drive center. Another one could be some type of stroke or brain trauma. So we'll say a TBI. These are things that actually cause damage to these particular areas of the brains and suppress the respiratory drive. So with that being said, these are the things that I want you guys to potentially consider if there's a respiratory drive suppression and there's no signals being sent to the muscles. The same kind of concept occurs. Hypoventilation of the alveoli will occur, nocturnal hypoxemia and hypercapnia will ensue, and they'll experience daytime somnolence. This is the big thing for sleep apnea. We come to the next kind of beast here, which usually shares some kind of similarity here. Most people who have OSA usually have obesity hypoventilation syndrome, or in some way, shape, or form. And most people who have obesity hypoventilation syndrome, about 90% of cases, usually have OSA. Why? Because the primary trigger and factor for these patients is obesity. So the way that we classify obesity is unfortunately not the best definition, but we use BMI. And when that BMI is greater than or equal to 30, we say that this patient is in the obese category. What that obesity does is something kind of interesting. One is, yes, these patients can experience sleep apnea. So one of the things I'll put up here is they also can have obstructive sleep apnea, 100%. There's about a 90% overlap between obesity hypoventilation syndrome and OSA. So you can definitely have what's called an OSA, OHS overlap. In other words, these patients could both have daytime somnolence and snoring events during the night, and apneic events witnessed by the partner. But the different concept here is obesity also leads to decreased chest expansion. If you have a big chunky layer out here, it makes it really difficult for the chest wall to properly expand. Because it's, you're having to have an obese abdomen, which the diaphragm is going to have to fight against, and you're going to have these intercostal muscles fighting against a big fat pad on it. And so because of that, this is inhibited or decreased to some extent. So whenever you have this effect here, you're going to get decreased chest expansion. And if the chest can't expand, can the lungs expand? No. And so it's going to be really hard for the lungs to be able to expand. And so as a result here, if we come down, we're going to see that this decreased chest expansion leads to decreased lung expansion. And by virtue, this will lead to these tiny little alveoli down here becoming hypoventilated. So if now from this decreased chest expansion, the alveoli don't get properly ventilated, air is not coming in here, air is not leaving here as well, this is unfortunately impaired. And then on top of that, the ventilation, movement of oxygen, and movement of CO2 will be impaired if alveolar hypoventilation ensues. So as blood runs through these pulmonary capillaries and leaves, what will you experience? The same exact thing. You'll have hypoxemia, low O2, and elevated CO2, which we refer to as hypercapnia. So you can have both of these here. We'll write this up here, right? So you're going to have both of these concepts occurring. But again, decreased lung expansion will lead to alveolar hypoventilation. And if the alveoli hypoventilate, you don't provide a good exchange of gases. And if there's no good exchange of gases, what's going to happen? You'll experience things like hypoxemia and hypercapnia. But here is the big difference. This can be nocturnal and while they're awake. That's the big difference. So you can have this occur nocturnal and awake. You don't have this occurring when they're awake in patients with obstructive sleep apnea. And so that's one of the big kind of differences here, is these patients live with a mild hypoxemia and hypercapnia day and night, where these patients live with the nocturnal hypoxia and hypercapnia only during the night because of their sleep apnea. But again, there's oftentimes an overlap between the two. This is not the only mechanism, though, that explains why patients have obesity hypoventilation syndrome in these complex kind of systems here. The other concept here, which is really interesting, is if you think about this, they have a hard time being able to clear their CO2, right? So this kind of expulsion of CO2 is being impaired. What happens is when CO2 is kind of built up, what does your body try to do in response to that? Breathe faster. Guess what these patients with obesity hypoventilation syndrome do? They breathe really fast because they take in small volumes. And so what will happen is these patients will have an increase in respiratory rate. So they'll look like they're working kind of harder to breathe. And they'll try and blow their CO2 down. Okay, and they may decrease their CO2 while they're awake, potentially, right? But here's the problem. When they fall asleep sometimes, this actually doesn't occur as well. So they won't be able to do this process. And so sometimes what happens is the CO2 will build up during the night. And then this will go here and keep trying to stimulate this actual respiratory center. That the respiratory center gets so dang annoyed, it's like, I ain't doing this crap no more. You're not gonna keep stimulating me all the time. So it decides to suppress itself a little bit. And it becomes less sensitive. So now what happens is you suppress this thing. You send decreased signals to the respiratory muscles. What does that do? Further decreases the chest expansion, worsens the lung expansion, worsens alveolar hypoventilation, and causes more worsening hypoxemia and hypercapnia. So that's one of these concepts of what we call diurnal hypercapnia, which is really interesting in this population. But either way, the same thing here, these patients will present with some type of somnolence. Usually daytime, in combination with that OHS, OSA overlap. Now, we have a patient who has either OHS or obstructive sleep apnea or the rare entity of central sleep apnea. What are the potential complications of living with this disease for a long time? Let's talk about that next. All right, my friends, so what are some of the downstream consequences of having either obstructive sleep apnea or obesity hypoventilation syndrome? So I think one of the big things is with OSA, it's those really intense nocturnal events of hypoxia and hypercapnia that are problematic. When these patients have that, one of the big things that can occur is they can develop things like secondary hypertension. One of the reasons why is that, again, they're experiencing things like hypoxemia. And that's a really problematic thing. So whenever you have things like hypoventilation and, again, periods of obstructive sleep apnea, this hypoxemia is a really powerful thing. When this occurs, what will happen is the blood will actually move through the pulmonary arteries. It'll move into the pulmonary veins, go into the left atrium. From here, it'll go into the left ventricle, out into your systemic circulation. Now, why is this a problem? Hypoxemia can be sensed by different types of chemoreceptors, and they'll activate your sympathetic nervous system. When your sympathetic nervous system becomes stimulated, what happens is this tells the sympathetic nervous system, hey, you need to really increase the amount of blood flowing through the systemic circulation. And so what it'll do is it'll actually activate your sympathetic nervous system. When your sympathetic nervous system is activated, it clamps down on your arterial system. So your arterial tree starts clamping down. When your arterial tree clamps down, what happens is it narrows the actual vessel lumen. So as blood is flowing through here, it's encountering more resistance to blood flow. So what do we call that? We say that there is an increase in systemic vascular resistance because of an increase in the sympathetic nervous system activity. When SVR goes up, as a result, blood pressure goes up. And as blood pressure goes up and it spikes above that 140/90 portion, then we say that the patient now has hypertension. But the hypertension is actually secondary to an underlying disease, and that is things like obstructive sleep apnea or obesity hypoventilation syndrome. So in states of OSA or OHS, which cause hypoventilation of the alveoli, this will then lead to the persistent hypoxemia, if untreated, which will then lead to the downstream consequences that we just talked about. All right? Now, having hypertension in itself is also problematic, if you can imagine. It can definitely lead to other complications. So this is a big thing to remember. All right, what's another complication? Another one is pulmonary hypertension. So it's the same exact concept. In patients who have things like OSA or OHS, again, they have hypoventilation of their alveoli. If you hypoventilate the alveoli, the big thing that can happen is they can have periods of hypoxemia. Now, hypoxemia will then, again, cause a similar effect, except hypoxemia is a very potent pulmonary vasoconstrictor. And so what it'll do is it'll cause a vasoconstriction of the pulmonary vessels. These puppies will clamp down. If you clamp down on the pulmonary vessels, what happens to the resistance to blood flow? It will cause an increase in pulmonary vascular resistance, which will then increase the pulmonary artery pressure, which will then lead to the ensuing pulmonary hypertension. So pulmonary vascular resistance will go up, and then as a result, pulmonary artery pressures will go up, and then pulmonary hypertension can potentially develop. Now, as a result here, if patients develop pulmonary hypertension, one of the big things that can occur here is that this can lead to the development of right heart failure. Just in the same way, essential or systemic hypertension can lead to left heart failure. So these are other potential complications, is the development of right or left heart failure from persistent hypoxemia and hypercapnia. All right. The next one here is atrial fibrillation. This one's actually extremely interesting and is becoming a very common cause of atrial fibrillation. Again, OSA, OHS, you're going to know this by the end of this, they cause alveolar hypoventilation. And periods of hypoxemia, usually intense during nocturnal time periods, but it can occur during the day in OHS. When this happens, again, what occurs? They develop hypoxemia. Hypoxemia is a what? Is a very powerful stimulus. So as blood is flowing through here, it doesn't undergo good gas exchange, moves into the left atria. The left atria, all right, they're very sensitive to hypoxemia, especially near the pulmonary vein entrance. So whenever there is hypoxemia, it'll trigger this kind of electrical activity. It'll increase the activity of ectopic foci, and it'll increase reentrant circuits. And these are things that'll then precipitate or worsen the patient's atrial fibrillation. So again, hypoxemia, persistent, can lead to increase in ectopic foci or reentrant circuits, and can precipitate or worsen the development of atrial fibrillation, right? So increase this from this particular stimuli. Now, what's the complication of having atrial fibrillation? You could go into acute heart failure. You could have tachycardia if you go into rapid ventricular rates, or it could even lead to thromboembolic complications. So these patients are at high risk for thromboembolic complications. That's also terrifying. All right, the last scenario here, if we come down here, is respiratory failure. Now, with respiratory failure, what can happen? This is usually more particularly pertinent in patients who have only obesity hypoventilation syndrome. In patients who have obesity hypoventilation syndrome, they experience hypoventilation during the day and during the night. So that's the big thing, right? Now, why this is a problem is because more people are aware of their breathing processes during the day than they are during the night, right? They're probably not aware of their degree of obstructive sleep apnea sometimes. But one of the things that happens is you are experiencing hypoventilation during the day and during the night. So because these patients hypoventilate, again, we said that they experience things like hypoxemia, and they experience things like hypercapnia. The important thing to remember is hypercapnia, we already said, can worsen the respiratory drive. So if we drew here that central nervous system, what did we say hypercapnia were doing over long periods of time if it's persistent? It was suppressing the respiratory drive, right? The other concept here is that not only does this lead to hypercapnia, it leads to hypoxemia. And when patients are hypoxemic, one of the things that happens is again, blood is moving through here. You're going to experience this low O2. Hypoxemia is a very strong stimulus for an increase in your respiratory rate. So it'll try to make you breathe a little bit faster. So these patients' respiratory rates kind of go up a little bit, and their work of breathing may become a little bit more increased. The problem is, though, is because of this hypercapnic suppression of the respiratory drive and hypoventilation continuing to occur, they'll still have increased respiratory rates and work breathing with low tidal volumes. Oftentimes, this type of respiratory failure can be misdiagnosed in a patient who has underlying COPD, and it can be potentially missed. And so that's really, really important to remember. But this type of respiratory failure would present more as a type 2 respiratory failure. So this would definitely present as a type 2 respiratory failure, given the presence of both hypercapnia and hypoxemia in the setting of hypoventilation. All right, my friends, so that covers OSA and OHS. I hope it makes sense, but now we gotta take a little bit of a deeper dive and really understand on how do we diagnose and treat these diseases. Let's move into that next. So how do we diagnose pulmonary sleep disorders, especially OSA? The first thing is a polysomnogram, because I told you OSA and OHS, they can overlap. You can have both. When you get a polysomnogram, what you're doing is you're doing a sleep test, usually in-house, and you're gonna have all these different monitors looking at your sleep waves. You're gonna have kind of this thing that takes a look to see how much you're actually breathing. It looks at your pulse oximetry, and it's looking at all of these different things to help us to register what's going on. Now, what we wanna look at here is a couple different things. Does the patient at any point while they're sleeping stop breathing, and does their oxygen drop associated with that? So then what we do is we calculate this thing called an apnea-hypopnea index. So let's say that the patient has a period where they kind of stop breathing, their oxygen levels drop. We can kind of look at that and call that an AHI event. And so what we'll do is we'll say, okay, let's say that they have these period of apnea-hypopnea events, and if it occurs in a specific amount, say 5 to 14 times, then that's considered mild obstructive sleep apnea. If it's 15 to 29, it's moderate, and if it's greater than or equal to 30, it's severe. But again, that would be super diagnostic of OSA, or even potentially you could still have an OSA-OHS overlap. Again, OHS can definitely cause patients to have obstructive sleep apnea. The difference is with OHS is this occurs during the day and night. So if you got a polysomnogram and it showed that their AHI was at least greater than 5, then we definitely have the diagnosis of obstructive sleep apnea. But the higher it goes, the more it tells us about the severity. But then if I wanted to say, okay, let's obtain an ABG during the daytime. If during the daytime I have an ABG and it shows that a PaCO2 is greater than 45 and their BMI is really high, they have greater than 30, that is way more suggestive of obesity hypoventilation syndrome, especially if I've ruled out other diseases like COPD, which is really tough to sometimes discern between this one. Okay? So again, polysomnogram, obtain the AHI. If it's greater than 5, it's diagnostic of OSA or OASA-AHS overlap. The higher it is above 5 determines the severity, as we see here. Get an ABG during the daytime, as long as you've ruled out other disorders and the PaCO2 is really high and they have a high BMI, it may be suggestive of OHS. All right, how do we treat pulmonary sleep disorders? So with OSA, it's all about keeping those airways open so that we can continue to allow the air to flow in so they don't desat and experience hypoxemia. So the best way to do that is to give them positive airway pressure, and we call this nocturnal CPAP. While they're sleeping, we hook up this device and it generates this constant pressure that's flowing into your airways during inspiration and expiration, so it keeps those airways stented open. That's one way. For the patient who has OSA and an OHS overlap, it doesn't matter. Treat them the same. Give them CPAP at night. It's going to do the same thing. But when a patient has OHS and an acute respiratory failure, so let's say that a patient has OHS, they have a problem, something develops, and now they have acute respiratory failure on top of this, then sometimes in that scenario, you just have to ventilate the alveoli a lot better, and BiPAP tends to be more beneficial and just sole a OHS. So if there's OSA at all, it's CPAP. If there's potential of OHS by itself, BiPAP is going to be the preferred measure. All right. Now, with any type of patient who has obstructive sleep apnea or OHS, it's always about treating the underlying cause, and usually that's weight loss or doing the particular surgeries. And that's really, really important. You have to treat the cause, and it's usually obesity. Weight loss, bariatric surgery is the biggest things. Now, alternative refractory therapies are also relatively interesting here. In a patient who has a very large uvula or a very large soft palate, sometimes you can do what's called a UPPP. And you basically kind of cut out the tonsils, you cut out the uvula and the soft palate, and it opens up this airway and kind of reduces the obstruction. So that's potential things that you could do if patients have very large tonsils, very large soft palate, very large uvula. The other thing is in patients who maybe have their tongue kind of back up into their airway and obstruct it, you can give them a hypoglossal nerve stimulator. And basically what it does is it comes from this kind of lead here that comes from the chest. And whenever the patient has this period of where they're obstructing, this kind of stimulator will go on. It'll cause the tongue to contract and move the tongue forward so it doesn't obstruct the airway. Kind of cool. The last particular thing is if you've had a patient who you've tried weight loss, they've tried bariatric surgery, they've done CPAP, they've tried if they had the things that you could correct like the UPPP, or if they felt potentially able to, hypoglossal nerve stimulators, and they failed all of those things and they really need to secure their airway, sometimes you can do a tracheostomy, but this is in the most severe or refractory cases. And that covers the treatment of pulmonary sleep disorders, my friends. And that covers this case and this whole discussion on them. I hope this made sense. I really hope that you guys did enjoy it. And as always, until next time.